So, good afternoon, everyone. At the outset, I would like to thank the organizers for providing me this topic, Quadratus Lumborum block. So, next 15 minutes, I'll be sharing tips and tricks for Quadratus Lumborum block. So, this is another landmark article. Those of us who are interested in Quadratus Lumborum block must go through this article, which is published in Anesthesiology Journal in February 2019. So, little bit about the nomenclature of QL1, 2, 3, and 4. When the drug is deposited on the lateral aspect of quadratus lumborum in the fascia transversalis, it is called as QL1 block or lateral QL. When the drug is deposited, I'll show you with a laser pointer. When the drug is deposited on the posterior aspect of quadratus lumborum at the lateral edge of erector spinae, it is called as posterior QL block. And when the drug is deposited between the quadratus lumborum and psoas major, this is on the anterior aspect of quadratus lumborum. So it is called anterior QL block or QL3. Now, a little bit about the thoracolumbar fascia. We have three facial, the thoracolumbar fascia divides into three as anterior, middle, and posterior layer. The anterior layer, as you can see, it covers the anterior aspect of quadratus lumborum. The middle layer covers the posterior aspect of quadratus lumborum. And then we have posterior layer, which is encircling around the erector spinae muscle. So the drug deposition is in and around the thoracolumbar fascia, and there was this group from Beijing which mentioned that the integrity of thoracolumbar fascia and more importantly the integrity of fascia transversalis, it is necessary for success of QL3 block. So the important tip while performing QL3 or anterior QL is we have to do needling more towards the transverse process side, and needle should not go laterally. The breach in fascia transversalis or breach in anterior layer of thoracolumbar fascia, it can cause spillage of drug in the peritoneal cavity or in the the fatty layer of kidney or aorta's fascia, and it can lead to inadequate action of block. So QL1, the drug is deposited on the lateral aspect of quadratus lumborum, and here, as I can show you, the external oblique, the internal oblique, and the transversus abdominis, and the needle is piercing the aponeurosis of the transversus abdominis, and the drug is deposited in the transversalis fascia, and it is on the lateral aspect of quadratus lumborum. So it is also known as lateral QL. This is similar to fascia transversalis block described by Dr. Hebert, and because the drug is deposited in the transversalis fascia, it has got a visceral component of pain relief other than the somatic component. So now coming to the posterior QL or QL2 block, which is another interesting block here. The drug is deposited on the in lift area, which is the lumbar interfacial triangle. So cadaveric dissection studies showed that there are no nerves here, and this is a dense facial area. So as we were discussing with Dr. Rafael Blanco, who discovered this block, he shared his view that the abdominal cavity or the abdominal whole of abdomen can be compared with a dense electric net, and this lift area probably is the switch button, and if we deposit the local anesthetic in this area, it can lead to some sort of a short circuit of whole abdomen, and it produces dense analgesia over whole abdomen. So if we are doing a bilateral QL2 or a posterior QL block, then it produces dense analgesia all over the abdomen. And this is the similar clinical experience in our institution also. Additional tip is when we are depositing the drug in the lift area, we can move the needle little bit posteromedially and deposit some amount of drug in that area as well. So here, as we can see, the internal oblique and the transversus abdominis muscle have become aponeurotic to form a lateral raphe, which splits into two lamina to form a lumbar interfacial triangle. And the drug has to be deposited on the posterior aspect of quadratus lumborum at the lateral edge of the erector spinae. Some amount of drug is also allowed to go in the posteromedial direction. So I'll be this block is I usually tend to prefer it in lateral position, but it can be done in supine position with little wedge or some support under the hip area. And the preferred probe for this block is linear probe, because with linear probe we can very easily see the spread of drug. And this is how Dr. Rafael Blanco is also doing this block uh, with the help of a linear probe. So if you are you want better success, I think the linear probe is the key. And what we see here is I'll show you. This is a very quick short video, and you can clearly see the quadratus lumborum. We can see the lateral edge of erector spinae, and this is the lift area. So there is no rocket science here, not much of skill set required. We just have to bathe whole of the lift area, and we have to just so around 15-20 mils of local anesthetic in the lift area, and then the needle is advanced posteromedially to allow the drug spread in the posteromedial direction between erector spinae and quadratus lumborum. So total around 25 to 30 mls of local anesthetic produces very good dense analgesia. So this was our patient who has undergone laparoscopic surgery, and this is the port site incision, and this is immediately after surgery. So there was no local infiltration at port site, and you can see how dense analgesia we have achieved. And even on squeezing the surgical incision, there is not much of pain. So it is always desirable to check the action of block at the end of the block, maybe after half an hour or so, when the block action has taken up, and we can expect good quality of analgesia. Coming to the another important type of block, which is described by Professor Borglum, and this is anterior quadratus lumborum or transmuscular quadratus lumborum, or TQL block, also known as tequila block. And here the drug is deposited between the psoas muscle and the quadratus lumborum muscle. So in between psoas and quadratus lumborum, here on the anterior side, we see many nerves, and the drug is deposited over the thoracolumbar fascia. And what is the mechanism of action is, we can see that as the drug is deposited, the drug tends to ascend up along the thoracolumbar fascia. It moves cranially through medial and lateral arcuate ligaments of diaphragm, and it has all its action because of indirect paravertebral spread. So this has been proved with cadaveric dissection studies. So if we are doing a block at L3, L4 level, it produces analgesia up to T4, and this is really nice. So only important aspect is we have to keep our needle more towards the transverse process side and do not allow it to go towards the aorta's fascia or the renal pad of fat. So this whole area and the depositing, so the drug between the quadratus lumborum and the psoas major. So this is the area which I am interested, and this is for my anterior QL. So is it that simple? I mean, just opening this interfacial plane, is that the end of the story? I think no, it's a little technically challenging block, because we need to understand. Now, this was our QL3 catheter, and this was a case of open nephrectomy. And as we can see, once the surgeon has done the surgical incision, and there was a big rent in the thoracolumbar fascia, and our catheter is popping in the surgical field. So where exactly we should deposit the drug? So we have quadratus lumborum and we have psoas major muscle. In between is the thoracolumbar fascia. So drug has to be deposited between the epimysium of quadratus lumborum and the thoracolumbar fascia. So position one is the correct one. Now, if we overshoot the target and if we cause breach in the continuity of thoracolumbar fascia, then our needle has gone still further in the psoas area, then it works more like a psoas compartment block and lumbar area. So instead of drug ascending up higher up to T4, it tends to move down, and this also has been proved with cadaveric studies. So there some amount of dexterity is required while performing this block. We can use PNS and keep the current on zero point 0.3 milliampere current. And if we see a local twitch of quadratus lumborum or psoas muscle local twitch, then we should not be depositing the drug. Once we are exactly in the plane, then there will not be any local twitch and we can deposit the drug. So the correct placement can be achieved by as the needle is advancing through the quadratus lumborum muscle, we have to do hydrodissection, gentle needling, and we try to achieve the end point, which is between the epimysium of quadratus lumborum and the thoracolumbar fascia. So this is these are some of the challenges while performing this block, and we are doing this block in lateral position. Usually the preferred approach is the shamrock approach. We all know the shamrock leaf and the shamrock sign and or the thumbs up sign. And this is one of our scanning video. Now here we are using a curvilinear probe, and what we see here is the quadratus lumborum muscle, the transverse process, and the psoas muscle, and we have to deposit the drug as the needle is coming. I'll advance it further. We can see it now more nicely. The interfacial plane between the quadratus lumborum and the psoas. And here also we have to do hydrodissection gently more towards the transverse process side, and we should not allow any spillage of drug or breach in continuity of transversalis fascia or the anterior thoracolumbar fascia. The drug should not be allowed to move in this direction. So the needle can come either in plane or out of plane more towards the transverse process side, and the drug is deposited between the epimysium of quadratus lumborum and the thoracolumbar fascia. So that's all about the drug spread. Now there is another variant called as subcostal quadratus lumborum block, and this can be done in sitting position, and this is nothing but a variant of QL3 block. And here the drug, here the probe is placed in parasagittal position near the transverse process. The patient is in sitting position. This can be done pre-operatively. We can use out of plane technique, and the view is similar, but here we can see the quadratus lumborum muscle and the psoas muscle, and the drug is deposited in between two. So bilateral block in sitting position just before surgery produces dense analgesia for whole of laparoscopic surgeries. So just the comparison between anterior and posterior QL. So anterior QL requires some amount of dexterity as where the needle tip has gone, and it should not overshoot the target. The integrity of thoracolumbar fascia and the fascia transversalis is necessary, and we are using curvilinear probe, and we should be careful about needling and should be near the transverse process, uh, more towards the transverse process side. Posterior QL, here the drug is deposited at the lateral edge of erector spinae on the posterior aspect of quadratus lumborum. This is like a switch button. There is not much of rocket science. Needling skill set required is not much because we just have to bathe the lift area and allow some amount of posteromedial spread between the erector spinae and the quadratus lumborum. So both blocks will have around 25 to 30 mLs of local anesthetic, and both blocks are promising for all laparoscopic surgeries, for all laparotomies. When we have operated spine or something where we cannot put epidural, these blocks are comparable with that of epidural. When it comes to lateral QL, the efficacy is limited to T12 and L1 area, so it is useful for all uh, elective C sections and open myomectomies. Now we have to use linear probe for QL1 and QL2 and curvilinear probe for QL3. Another important thing is whenever we perform QL block, it is always bilateral. If the surgery is laparoscopic surgery, we have to do a bilateral block. I have seen some of my residents, they said that patient has undergone lap cholecystectomy, so we'll do a unilateral block for lap col. I think that is not a good idea. And these are all interfacial plane blocks, so it depends on volume. So we should be using modest dosages and to have the better efficacy. Thank you very much for patient hearing.